Hello, I'm Dr. Richard Bogan, and on behalf of CME Outfitters, I would like to welcome you and thank you for joining us for episode 2 of the 4-part CME OCAST series, Fine-Tuning Diagnosis and Management of Excessive Daytime Sleepiness in Patients with Narcolepsy and Obstructive Sleep Apnea. Today's episode is titled Matching Treatment Choice to the Pathophysiology of Sleep. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Again, I'm Dr. Richard Bogan, president of Bogan Sleep Consultants, medical officer at SleepMed Incorporated, now BioSerenity, and director of SleepMed of South Carolina. I'm also the associate clinical professor at the University of South Carolina in Columbia, South Carolina, and associate clinical professor at the Medical University of South Carolina in Charleston, South Carolina. I'm very pleased to introduce a national and international expert, Yves Dauvier, professor of neurology and physiology at the University of Montpellier. This is a Southern fellow pronouncing French, so I apologize. And he's director of the Sleep-Wake Disorders Center, Department of Neurology at Montpellier in France. So Yves, welcome.
Thanks, Rick.
So let's get started. To frame today's episodes, let's start by reviewing our learning objective, which is to evaluate the significance of the mechanism of action when selecting optimal treatment of excessive daytime sleepiness in patients with obstructive sleep apnea or narcolepsy. In the sleep clinic, obstructive sleep apnea is really one of the most prevalent disorders that we see, along with insomnia. But the majority of those patients are sleeping. Of course, narcolepsy gives us a window into some of the sleepiest individuals in the world. And Yves is going to walk us through basically brain state stability, how the brain stabilizes wakefulness. So Yves, let's begin with a brief overview of the neurobiology of sleep and wakefulness.
Yes, thanks, Rick. So I think we need first to divide the sleep and wake regulation system into two major pathways. The first is arousal systems that include a lot of different neurons and related neurotransmitters with norepinephrine, acetylcholine, serotonin, histamine, dopamine, and orexin. And all of these neurons will be part of the game to induce your arousal, so the wakefulness. In contrast, there's the sleep onset systems, mainly driven by the VLPO, with one major neurotransmitter, namely the GABA. And to be awake or to be in sleep state, there is a competition and imbalance between the monoaminergic neurons. So again, histamines, serotonin, norepinephrine that need to be active when you are awake. All this is driven by the orexin activity. And in contrast, when you fall asleep, you will activate your GABA neurons within the VLPO to inhibit the orexin and the monoaminergic neuron. That explains how it works when you are asleep or awake during the daytime.
Yeah, it's pretty clear that there's a lot of redundancy here in terms of trying to stabilize state. The brain obviously wants to be in one state or the other, wake or sleep. So it's obvious that this is very complicated. What actually happens in the neurobiology of narcolepsy type 1?
So in narcolepsy type 1, we know that since 2 decades right now that there's a loss of orexin neurons in the brain. And at the consequences, when you measure orexin, also named hypocretin, the same peptide in the CSF, it is gone. It's no more. It's below 110. And that explains in the patient with narcolepsy type 1 daytime sleepiness, sleep onset REM period, and the cataplexy. And it is really a nice discovery 2 decades ago. And because of what we discussed, that orexin will drive the monoaminergic neurons. If you have less orexin, you will have less norepinephrine, less dopamine, less histamine. And that explains especially the sleepiness we are discussing today.
Yeah, when I talk to some of my patients, we talk about state instability, and patients with narcolepsy sort of oscillate back and forth between wake and sleep in the daytime and at night as well. And they have these REM intrusions, REM dissociative symptoms. And clearly in narcolepsy type 1, we have more insight, but narcolepsy type 2 and even idiopathic hypersomnia, which we won't get into, but narcolepsy type 2 is another disorder, really. Do you want to expand on that?
Yeah, so unfortunately, the neurobiology of narcolepsy type 2 is less clear. For narcolepsy type 1, it was in the past known as narcolepsy with cataplexy, and we were interested in assessing orexin within CSF in narcolepsy without cataplexy, and 20% only do have low level of orexin in the CSF. So they are named right now narcolepsy type 1. So in narcolepsy type 2, by definition, there is no more orexin within the CSF. And we can speculate that a part of these neurons, of orexin neurons in the brain, are gone, just 20%, 30%, but who knows exactly? So we may say that is almost unknown. We work on histamine assessment, on MCH assessment, on orexin assessment, and right now nothing came up as a good biomarker to explain sleepiness in narcolepsy type 2. So the neurobiology of daytime sleepiness in narcolepsy type 2 remain unclear.
Yeah, thank you, Yves. And then we move on to obstructive sleep apnea patients. Clearly, when patients present to us, they have fragmented sleep and oscillations. They have oxidative stress and many things because of the increase in upper airway resistance and obstructive events. But some of those patients, when we treat them appropriately, they're adherent and their AHI is normal and airway resistance is gone. They don't snore, but some of them are still sleepy. Why is that?
Yes, excellent point. So we do see 10% probably of patients with sleep disorder breathing with still sleepiness, despite the fact that they are correctly managed with CPAP machine. But there is a lot of variability to explain this sleepiness. That may be some comorbid depression, comorbid obesity, some drug intakes, or insufficient sleep syndrome and central hypersomnolence disorder that may also coexist with sleep disorder breathing. So we need really first to phenotype as best as we can and to record sleepiness in those patients, and not only by clinical interview or by questionnaire, to be sure that they are really sleepy and not just fatigue. And in this population of selected target population with really sleepiness assessed, as for NT2 and you briefly touched, but IH is almost the same. We do not know. We may speculate that some orexin or norepinephrine, also awakening neurons, are gone because of hypoxia repetitively before being treated with CPAP, but it's not clear if this really happens in the brain of patients with OSAS, and especially in those who are sleepy despite being treated with CPAP. So I think it's more hypothesis and speculation than really some nice results. So the pathophysiology to explain EDS is unclear, and we really need to work on it to understand better this field.
Yeah, I completely agree. It's interesting that the evidence, the objective evidence, is early, but there is some suggestion that some of these monoaminergic sites in the brain are more sensitive to oxidative stress, and that might have some influence. And then, of course, there's some evidence out of Chicago that showed conductivity issues as well in terms of how the myelin sheaths work in terms of communicating. But that's very early work. But what we do know is that as clinicians, we see patients that have excessive sleepiness. And of course, many of those patients are significantly impaired. We have to make sure they're adequately treated, and we have to rule out other sleep disorders and medical problems and psychiatric issues. But some of the patients deserve therapy, and we now have some therapies available. And since you've talked to us about these neurotransmitters, how does that inform you in terms of how you would treat these individuals?
Yes, I think we need to recognize that daytime sleepiness is not the same for all the different disorder. Again, NT1, NT2, OSAS, and also IH is they do complain about daytime sleepiness, but in different manner, different phenotype. And it's of interest to understand better and better for which drug will be the best for which phenotype. And I think there's two things we need to discuss on today, and we already discussed about the what is the neurobiology, still mostly a mystery in most of this condition, but probably more and more we will know about that, and that may explain it for precision medicine who will need this kind of medication. This is the first step. And the second step is the severity of the condition. Severity of sleepiness is variable in terms of the different background, and also within the same disorder. In narcolepsy type 1, as an example, we do have some mild cases, moderate cases, and severe cases for sleepiness. And we cannot decide to treat in the same way this different population. So I think that symptom severity and the background of what may explain sleepiness in those populations need to be the goals to better treat the patient at the end.
I agree. I mean, it's certainly we have drugs that have been approved to treat narcolepsy and certain drugs that have been approved to treat obstructive sleep apnea, individuals with persistent sleepiness. Of course, we always want to make sure that they wear their CPAP device. Do you want to talk about those classifications of medications that are available?
Yes, so there is right now some pipeline, we can say, but there's traditional stimulants, methylphenidate and amphetamine. There is the modafinil and armodafinil, wake-promoting agent, the solriamfetol, and sodium oxybate, and the non-salt. So there is the different player that may improve daytime sleepiness in those different conditions. And of interest, the how it works is completely different and could be of interest for the target population. We need to use this medication for specific patient. And for methylphenidate, so traditional stimulant mostly work on that. So the transporter of dopamine, the transporter of norepinephrine called NET, and the transporter of serotonin called SERT. And they do have a high affinity for this three transporter. In contrast, modafinil have a low affinity for one of these transporters named the DAT, the transporter of dopamine. And recently, the solriamfetol have also a low affinity, but for both transporter, dopamine and norepinephrine. So it's different than modafinil and methylphenidate mechanism of action. And sodium oxybate is very known with a high affinity for GABA B receptor in the brain with selective activity. And the GZP-258 is the same mechanism of action, is just a low salt xyrem, so the same mechanism of action.
Yeah, it's interesting because and you pointed out that each of our patients are different. And for example, I remember a patient who came to me with narcolepsy who said, "Doc," he managed his sleepiness, but he said, "Doc, I dream all night. I'm very aware. I go to sleep and I'm aware of my sleep. I dream all night. I wake up a lot, and this is what bothers me." So we obviously have to listen to our patients and fashion and recognize that some patients respond in one way and other patients respond in another way. And part of that's based on these mechanisms of action. Would you comment on histamine? Because that's a new drug that we now are using in terms of pitolisant.
Yes, so there's a lot of, as we discussed, different transporter of this monoamine or an histamine have also its own transporter is named H3 at the presynaptic level. And if you block the reuptake of histamine at the presynaptic level, you will increase histamine in the synaptic cleft, and that will be metabolized to telemethylhistamine, being a more stable metabolite of the histamine. So with the pitolisant that block exactly what I'm discussing on this H3 presynaptic receptor, it will increase the level of histamine. And if you increase the level of histamine, you will decrease the sleepiness, increase the REM sleep latency, and decrease the partial cataplexy. So I think it is, again, one of the big players like norepinephrine, dopamine, orexin, and it's nice to have a new compounds who work in this direction.
Yeah, we have a lot more opportunities now in terms of our treatment. So interestingly, when we attempt to use sodium oxybate or now the low salt oxybate preparation in patients, it's difficult to explain that to the patients sometimes. They're like, "Wait a minute, you're going to give me something at night. I already am sleepy. How does that work?" And um, I sort of tell them it turns off the awake circuits, and then when it wears off, they upregulate. But obviously, the science is more sophisticated. Would you talk about GABA receptors, GABA A and GABA B, but obviously GABA B receptors?
Yes, it's mostly GABA B because GABA A is for benzo, and it will reduce your slow wave sleep and induce sleepiness during daytime. So GABA B is actually the target of sodium oxybate and also GZP-258, and it is very selective, high affinity with this receptor, and it works in activate this at night. And because you activate the GABA B, you will change your dopaminergic level in the brain, and mostly inhibiting it at night, and there is a shutdown, so there is a rebound during the day, and you will increase your dopamine tones during daytime. That may explain the efficacy on sleepiness and decrease of cataplexy. And of interest, we need to stress on that the activation of GABA B, so namely the sodium oxybate pathway, is the only drug so far known to increase slow wave sleep. And this is a good target for many patients to improve their bad sleep at night, mainly for narcolepsy. And who knows about other condition, but for narcolepsy is quite clear.
Yeah, I wish we had time to kind of go into the pharmacokinetics because it's a very short acting molecule, has a short half-life, so you have to take 2 doses. And yet the next day the patients have less sleepiness and the cataplexy is significantly improved. So it's a very interesting molecule. But I think what you've done is, I mean, it's phenomenal presentation in terms of helping us understand the neurobiology of sleep and the science behind this targeted therapy. So let's close with our SMART goals. That is very specific, measurable, attainable, relevant, and timely goals. And Yves, what do we hope that the healthcare practitioners listening today will take away from this podcast?
So yes, I think we need to clearly identify the key neurotransmitters that are involved in sleep-wake regulation, and particularly dysfunctional in patients with narcolepsy type 1, type 2, and OSA. So we know quite clear on NT1, less on the 2 other conditions, but we need to work more in this direction. And the second goal is to recognize that many different drugs target exactly the key neurotransmitter we just discussed on, and that explain how it works to manage sleepiness in patients with narcolepsy and patients with OSAS in different manner.
Yes, thank you very much. To receive CME CE credit for this activity, click on the link identified here to complete the post-test and evaluation online. Please visit the Sleep Disorders Hub at cmeoutfitters.com, Sleep Disorders Hub, for additional educational activities, resources, and tools to improve the care of patients with excessive daytime sleepiness. Thank you for joining us today for episode 2 of our 4-part CME OCAS series. To view additional episodes on an overview of EDS and the burden it imposes, differentiators when choosing novel treatment options for EDS, and diagnosing and treating pediatric narcolepsy with cataplexy, please visit cmeoutfitters.com. Thank you again for participating, and thank you for providing the best care for your patients. And a special thanks to Yves for this phenomenal scientific presentation.
Many thanks, Rick.